Hello, everyone. Welcome back to Hot Seat Season 2. I'm Omid Moghaddas joining you from Tehran. And once again, I'm so grateful to be with you all from this educational platform with great names in the field of implant dentistry from around the world. And I have to say, I'm so thrilled that these amazing friends accepted the invitation and are joining us from this educational platform to help everyone, all of our colleagues around the world, especially those interested in learning more, to increase their level of education and to learn best. And as you all know, over the past seasons and past sessions, we talked about almost all aspects in implant dentistry from a prosthetic point of view to the surgical point of view. We talked about complications, soft tissue augmentation procedures, bone augmentation procedures. And today we have a very interesting topic to cover, which we haven't talked about it before. And this is one of the challenges that usually practitioners may face in doing bone augmentation procedures, and most specifically about vertical augmentation procedures in Khoury technique. And that's how to harvest safe and predictable bone plate the way that we want. And who can be better than Luca de Stavola, my dear guest, at this part of Hot Seat to cover this session, because he's a true master clinician and expert in this field. And the topic that he will talk about for us is about computer-guided bone harvesting for vertical bone augmentation, which is a unique topic, and he's also a unique lecturer. So, Luca, my dear friend, welcome to Hot Seat, my friend, and thank you for accepting the invitation.
Thank you very much, Omid. For me, it's a great pleasure being invited, and I'm honored of these chances to share my knowledge for the next hour together with all the people who wants to dedicated me a little bit of their time. I'm sure that they are going to be happy to what they are going to see. I hope to stimulate them to maybe change their way of performing clinical approaches, thanks to the technologies that every day is going to simplify our work. So thank you, Omid.
Exactly, my pleasure, and I'm sure
I am going to share my.
Yeah, you can share
fantastic.
your. But before you start, I would like to have your CV for all of our audience. Absolutely, you don't need any introduction because everybody knows you. But as a tradition, I would like to have your CV, and then we will really go to your presentation. And at the end of it, we will have a great discussion on the topic. Luca graduated in dentistry from University of Padua, Italy in 2001, and postgraduate program in oral surgery at Professor Fuad Khoury's clinic in Augsburg, Germany in 2007, and received a Master of Oral Medicine in Implant Dentistry from University of Münster in Germany in 2007 too. He is a member of the European Association of Osseointegration and Italian Academy of Osseointegration, invited a speaker in many courses and congresses since 2005, in particular at the Society of Periodontology Annual Congress, SEPA, 2016 and 2018, and EAO Annual Congresses, 2017 and 2019. He is the author and co-author of peer-reviewed manuscript published in international journals such as JOMI and IJPRD, and visiting professor and lecturer at the University of Padua in Italy, Eastman Institute, UCL, London, UK, University of Vanvitelli of Naples, Italy, and University of Reggio Emilia and Modena in Italy. Also, he has a private practice in Padua and Treviso in Italy. Once again, I'm so honored to have you, Luca, and we are ready from head to toe to hear your beautiful presentation.
Thank you very much, Omid. So I'm going to share my screen and start with my lecture. So I just need to have a feedback from your side if everything is running good. You see my screen now, Omid?
Everything clear.
That's good. Perfect, perfect. So I'm from Padua, as you said, which is in the north east of Italy, close to Venice. It's a relatively small city. We are around 300,000 people, but it's tremendous, with a tremendous background and history. So my topic is the computer-guided bone harvesting for vertical bone augmentation. And why this topic? This topic because we know that when we are working on patients and we have a goal in our treatment, obviously there are some clinical treatment that let us work in a confident environment. It means that, for example, we are working in a front area and all the hard tissue and the soft tissue are present, we are not very worried about the outcome of this treatment, because it's obvious we have to manage the three-dimensional implant position, but everything is already in place, the bone and the soft tissue. And in these cases, the result is high predictable, and the maintenance of the result is high predictable, and is what we are usually looking for when we are treating this type of patient. And it's obvious that this is going to give us satisfaction from a clinical point of view. The patient is satisfied, and we are in a comfort zone, in a comfort area. So anytime we have the same basically problem, clinical problem, we can solve this quite easily because we are confident with the treatment. Also, when we are talking about small deficiencies like this, when we have horizontal discrepancy due to the tooth loss, and we want to build back this volume, we are quite confident on the procedure we are going to perform, because this is something that is already demonstrated by the literature many times. We have relative simple surgery, a relative small amount of autogenous bone needed to treat this type of deficiency. Then we are going to wait just time, but everything is running in a so-called comfort zone also in this treatment scenario, because everything is quite routine performed. This is true for many, many clinicians. And so that we can obtain good results from an aesthetic point of view after we establish the bone volume, and we have stability of this bone during the time, during the follow-up. This is 4 years. And you can appreciate also from a CBCT data that everything is nice and stable. And this stability of the bone is going to support the soft tissue in the right and adequate way. And this is going to be really stable if you're comparing the 1 year and the 4 year result. And also when you are looking clinically after 6 years, the result is very nice. And the therapy is successful. And this is in dynamic, the 6 year, and you see that the treatment able to reestablish a nice smile for the patient, a very natural result from a smile point of view, and the patient is happy, we are happy. And anytime we can go back in a situation similar to this and perform again procedures with the little amount of autogenous bone and with bone substitute to reestablish the outside contour. And you see the stability after 7 years and the clinical stability again after 7 years. Everything is nice, very, very stable. And if you compare the 1 year and the 7 year, everything is really perfect from the shape of the reconstructed bone. And once again, these are the situations that we are approaching and we are treating every day, and we are very confident with. So optimal clinical situation and also slightly compromised situation we can manage in many, or for many clinicians, is something that is on their background, I would say. So they are not afraid on the final result. They are not stressed by the treatment or what they are going to talk to the patient or propose to the patient for the treatment. But what about these cases? What about those patients where everything is compromised? It's obvious that this is a limit case. This is, I'm a dentist, I'm a neurosurgeon, but this is in the limit of a dental approach. But anyway, between an optimal condition and this condition, there's a lot of situation where the bone orientation, or better, the tissue that we want to build back, is going to play a fundamental role for having the osseointegration of the implant and the stability of that osseointegration during the follow-up. Because in these cases, we are not looking just to build up a volume. It's not just to build up to fill that gap, to have the soft tissue shape that is going to change. Here we need to have back the bone, otherwise the implant are not going to be placed in the right tissue. Osseointegration is not going to happen, and then the maintenance of that osseointegration of that implant function is going to be impossible. So these cases are those cases where mostly of the clinicians are not anymore in their comfort zone. So where they have doubts about the possibility to treat this case. Also, like is like this, where everything is missing, we are missing even the bone. And these are those cases that I see more and more in my office because our implant failure treatment, maybe with implant placed 15 or 10 years ago, and due to perimplantitis, they lost completely the osseointegration and they destroy completely the alveolar process. So which is our answer for this type of scenario, or these cases where perimplantitis destroyed completely the alveolar crest? So obviously, for many clinicians, this situation is not anymore in their comfort treatment area. So the case starts to be very stressed for the dentist. How to perform, how to manage the soft tissue, which type of material should be used for the vertical augmentation to bring back the bone. And also, if I decided that I'm working with autogenous bone, the question is how I'm going to be able to collect all the bone needed to perform the surgery. Can I do it in a safe way, or it's going to be a very stress moment? I have to manage close my osteotomy lines close to the anatomical structure. So I will be able to bring the final result, or what the expectation of the patient. Can I reach the expectation of the patient? Because it's obvious that all in these cases, there is not a diagnosis problem. I mean, when you see a bone deficiency and you know more or less where it's going to be the tooth, the final tooth, it's obvious that you can imagine easily how the bone should be and where the implant should be placed. So it's obvious, and this is true for the upper jaw or the mandible. I mean, we know where we want to go. So it's not a diagnosis problem. What we want, and also in the aesthetic area, we want to build back the volume, the hard tissue and the soft tissue, and see the stability also of this tissue among the time. So once again, the problem is not related in these cases to the diagnosis. The main problem here is related to the chances to get the bone to perform the treatment and to be predictable by doing this and by performing the overall treatment. So what I want to focus now is the bone harvesting, and just to spend words about what is bone harvesting today, or what was for me yesterday. And when I mean yesterday, I mean 8 years ago, because 8 years ago, bone harvesting for me was a challenging moment. I know that I'm coming from Fouad Khoury school, so I learned very well how to harvest the bone. I manage also to to manage my stress during the surgery. So also to place the osteotomy lines close to the nerve, close to the alveolar canal, close to the teeth. And anyway, anytime to perform it, try to maintain the risk very, very low. And why we have to talk about risk? Because at the end, bone harvesting is a successful procedure performed freehand, there's no doubt. There's a lot of study, for example, one from Luca Cordaro in 2011, that explain clearly that this treatment, this approach is well tolerated by patient. We have the Curie study from 2015 with more than 3,800 patients, 800 bone harvesting procedure performed with a very low complications rate. Because at the end, the guideline when we are talking about freehand bone harvesting are quite clear. We have to work in the external oblique ridge, so not too much into the ramus, or better would be application is not going into the ramus, because then is going to be quite dangerous. We have to work on the buccal shell close to the second and third molar. But we need to have in mind anyway, which is the relationship between the external oblique ridge and the alveolar. In particular, we have to focus to the fact that when we are moving more distal, close to the ramus, the alveolar canal to be very close to the surface. So when we are working freehand, we should stay more mesial compared to the ramus area. And theoretically, we should stay also cranial to the nerve. So when we are working on the CBCT in the diagnosis phase, we can really measure the thickness of the cortical plate. We can take reference point in relation to the tooth, in relation to the ramus area. And we could think also to work in a relative safe way. So controlling on speculating that we are fine. But there's a point. At the end, also when the diagnosis phase is going to be performed with the best technologies available, we still don't know exactly where are our osteotomy lines. It means that we suppose to be in the right position. We suppose to be in the external oblique ridge and not in the ramus. We're supposed to be cranial to the nerve and not crossing the nerve. But due to the fact that we suppose this, all the techniques that has been proposed, the microsaw, the piezo, the Lindemann bore in the past, time used just on the surface of the bone. So none of these approaches is going to cut the bone in the depth, because we really don't know where we are moving, or if we are too close, or we're going to be too close to the nerve or to the root. So for example, Clavero and Lundgren said that we should not go through the cortex for the osteotomy, inferior osteotomy. Luca Cordaro said to avoid the apical osteotomy, or for example, Curie said not to go deeper than 2 millimeters with the diamond disc in the distal area, particularly when we are distal to the second molar, close to the third molar, because the nerve is quite close to the surface. But we perform a study that has been published in Journal of Periodontics and Restorative Dentistry and was published in 2019. And we perform it on 50 patients, so real patients that we have treated for bone harvesting. And we check on this line that you see here, this dot line, vertical, basically in the anatomical limitation or the limit between external oblique ridge and the ramus. And we found that in 26% of the case, there was less than 2 millimeters from the outer surface of the nerve and the nerve. It means that also using the diamond disc not deeper than 2 millimeters, in 1/4 of the case was too deep. So this should be a sort of alarm when we are thinking to work in that area to harvest the bone, particularly when the bone harvesting is going to be of important dimension. So when we are going to treat big vertical deficiency, and when we need to treat important vertical deficiency, it's obvious that our osteotomy lines are going to be brought to the limitation, to the anatomical limit, so very close to the ramus in the distal area. So we need to keep in mind that also in 1/4 of the patient, we should have, or we could have, a very limited amount of bone between the external cortical plate and the alveolar nerve. So we need to be very conscious by performing this type of procedure. And the guidelines basically is to stay cranial, but it's not so obvious to stay cranial, because when you're looking to the paper by Khoury in 2015, almost 60% of the case, the osteotomy line were crossing the nerve. Then it depends when the cross of the nerve is performed, but in 7.3% of the cases, there was a nerve exposure. Now, this doesn't mean that we are going to have damage of the nerve or alteration in terms of function, but it's a stress point for the surgeon anyway, thinking that we could be very close to the nerve, or then we are, when we are performing the bone luxation, we can see the nerve. I mean, when I was by Khoury, was something that was happening, I would say not daily and not weekly, but anyway, we were used to manage also this stress. But thinking to someone that learned the technique and never spent 3 or 4 years in the Khoury's clinic, this is a stress point. And as I said, this can happen. And this is my case, for example, when I have a luxation of the block, and you see in the distal area, you have the nerve. It's 5 millimeters in the depth. But this is happening because we are working on the surface of the bone, and then the fracture line is running uncontrolled inside the bone. So sometimes it happens that we have nerve exposition, which is not a problem, big problem. But anyway, is a stress moment. But the worst scenario I had in my career was when I had the nerve luxation, the block luxation, and the nerve was trapped into the block because the fracture line was ran lingual to the alveolar canal. So what you see there close to the section instrument is the nerve, which is trapped inside the block. So I had to spend a little bit of time to break the trabecular bone that was locked the nerve inside the block, and then I was able to luxate the block. And once again, there was no net damage to the nerve, but I have to say that I lost 10 years of my life in those 20 minutes, because it's obvious that was a very stressed moment. Now, but this was a starting point. This was a starting point to think something different. It means that, can we change our approach? Can we be more predictable when we are performing osteotomy lines? Or we need always to speculate? Now we have CBCT data that allows us to perform a fantastic diagnosis. But how we can bring those information inside the surgical field? Cannot be everything linked to our mind and our capacity to work freehand and simultaneously think about the anatomy that we saw on the CBCT data. So now the technology can help us not to be so, not to speculate on our position, but can help us to be very close to the optimal position. We know this from implant. think about computer-guided implant placement or dynamic navigation implant placement. I mean, it's not 100% the same position, but we are very close to it. And this type of technology can be brought also in the bone harvesting procedure. So what we have developed in 2012 that was internationally patented in 2013 is the computer-guided approach, that then was published in JOMI the first time in 2015, so 3 years after the patent approval, and is a completely digital approach to harvest the bone and to shape the harvesting based on the quantity of bone needed to perform vertical bone augmentation. So we can basically decide it in advance before starting the surgery if we're going to be able to collect the bone in a safe way. And that's very important. That is going to change the game completely because I'm not stressed anymore. I prepare everything, and when I'm working, I need just to follow the planning. What is the meaning of this? Obviously, we're going to have a digital workflow very close to the implant digital workflow. We need to acquire the volumetric data with the CBCT acquisition. Then we're going through a digital process of osteotomy lines. Basically, we perform the surgery in the digital world. And then we have through a CAD/CAM process, a template, which is a safe CAD guide, is working like a three-dimensional ruler so that we can perform the osteotomy lines exactly in accordance to the planning. So I want to share with you the workflow. Look into this case that I presented also at the IAO in 2017 in Madrid, and where I was sharing the podium with Joseph Kahn and Markus Hurzler, and was the treatment of the vertical bone deficiency in the aesthetic area. And for me, it was a very great moment from a professional and human point of view. And I want to use this case because for me is a fantastic case. So you see the patient has a periodontitis that was very bad in the front area. We have some hopeless teeth, particularly the lateral and the central incisor. We have a big problem from a functional point of view. You see the situation is absolutely not nice. And we have also a vertical deficiency. This is after the extraction of the teeth. We wait 2 months so to have a nice soft tissue healing. And here we perform a CBCT data acquirement, and you're going to appreciate that we have a nice vertical deficiency, not just an horizontal, as was looking on the clinical picture, but we are missing bone all vertically. It's around 5-6 millimeters in the front maxilla. So this is the gap between the teeth, the final teeth, and the bone. Obviously, we have to consider also the emergence profile. So we are not going to augment 8 millimeters, but just 5 millimeters. We need to bring the implant shoulder 3 millimeters from that point. So that is limited vertical augmentation. But this is what we are doing at the beginning. So we measure, we have linear measurement of the deficiency, so mesial to distal. And then we go to the lower jaw. We look to the external oblique ridge. And when I was performing these freehands, I was just designing the osteotomy lines, and I bring this planning mentally in the surgical field. So with no reference point, just thinking to replicate what I have in my mind in terms of dimension, in terms of working depth. But nowadays, or better nowadays, since 2012, we are performing the process completely digital. So we're looking at this animation that was performed by PerioPixel, my good friends in Madrid. So we are designing the osteotomy lines, not just on the periphery of the bone. So we are selecting the mesial dimension and the height of the block, keeping in mind the anatomical structure of the alveolar nerve, but we are selecting also how to cut the bone inside. So we are checking our osteotomy lines three-dimensionally. And the outside projection of these osteotomy planes are going to represent the internal face of the surgical template. What is the meaning? That these osteotomy lines are going to be the inner face of a surgical template. So the surgical template then is going to be used to, as a three-dimensional ruler to perform the osteotomy lines exactly as planned. So we are going to approach the surgery the typical surgical plan. So for each segment, I'm going to have the direction and the working depth. Like when we are placing implants, guided, we are going to have for each position the working depth and the diameter of the implant. In this case, we are going to have the direction, the working depth of each osteotomy segment. So we are going to perform the procedure that has been called SafeCut, computer-guided bone harvesting. And the procedure is very close from a flap design to the typical freehand approach. So we're going to have an incision foot thickness on the external oblique ridge with the distal and a mesial releasing incision. We're going to open the flap foot thickness to denudate the bone on the cranial aspect and on the lateral aspect. This is a typical approach for freehand bone harvesting. But when we are opening the flap here, we are having no reference point. So what we are doing, we are going to get, sorry for the sound, but we are going to have the use of the surgical guide that allows us to have a three-dimensional ruler perfectly placed in position. And when we are facing the piezoelectric tool against the interface of the surgical guide, we are going to follow the osteotomy line. So we are fully guided. Obviously, the piezoelectric tool is working perfectly with this type of approach because it has a flat tool, and the flat tool is going to be faced against the interface of the surgical guide. So we are performing the vertical osteotomy and the mesial osteotomy with the straight tool, and then we are changing with the angle tool, angulated tool, to perform the apical osteotomy. Everything is running very, very clear, crystal clear, because we have all the references. That I'm not looking to any x-ray during the surgery. I have no need to look to an x-ray because everything is planned. I don't need to change something. I need just to follow what I have decided in advance to do. So also my stress is very, very limited. I'm not just forming the osteotomy lines on the surface, but I'm going to bring the osteotomy lines very close to each other so that the elevation is not performed by hammering the bone, but is just by placing the elevator and turn it on his long axis and the block is out. So the patient doesn't realize what is going to happen. And then if it is needed, we can place a sponge on the site and close the wound. So we are going to see now how was performed the surgery in this specific patient, and we're going to see the flap elevation, which is very close to the typical approach as described by Curie or other authors. We have a distal incision towards the ramus, then we elevate the full thickness flap, and also on the lateral side. And look here, if we are looking to this picture, which is the typical picture that has been shown by a freehand approach, now we should start to speculate which is the position of the ramus, which is the position of the root, the axis of the root, the vertical position of the alveolar nerve. It's obvious that we can do freehand, and we can do it as has been done for many, many years. But we can do it also with less stress. We don't need to be brave to perform this, or very skilled surgeon. We need just to follow, once we have in the surgical template, we need just to follow what the template is going to indicate. You see that now everything is completely different on our eyes, because now I know exactly where I have to perform my osteotomy. I need just to place my my piezoelectric tool, face it against the internal face of the surgical template, and like working with the pen and the ruler, I'm going to perform the osteotomy line. So it's very easy and crystal clear how to perform this osteotomy. And I'm not stopping when I'm crossing the cortical plate, but I'm bringing down to 7 millimeters, because that is the plan. So I know that working till 7 millimeters in that area will be with no risk. And I'm limiting my fracture line to a 1 millimeter or 2 millimeter. Even sometimes there's no fracture line, because everything is going to be performed. And then I'm going on the apical area, and I do the same thing with the angulated tool. You see that we are just placing the piezoelectric tool against the internal face, and then we follow the direction given by the surgical guide. So it's very, with no stress at all, very controlled. Everything is going to be done maintaining a high level of safeness from the nerve and the anatomical structure. So we are away, we can luxate easily the block, and we have our block in the hands in 20 minutes working, and we have all the bone needed. So I know since the beginning that I'm going to get the bone and the exactly dimension that I need to perform the vertical augmentation. And you see here the accordance of the osteotomy lines and the internal face of the surgical template. So everything is running very, very easily. And this is a bidimensional control after the surgery. But look the relationship between the apical osteotomy in the planning and the apical osteotomy on the bidimensional image. You're going to see that we're very close to the nerve, but we are always cranial to the nerve. So we are in a perfect position. And then what we're going to do the upper jaw, we are following the Curie's approach, the typical Curie's approach, but we have all the bone needed. So I was not using the probe to be sure to collect the right bone dimension. Everything was fixed before going to the surgical field. So here we are building up vertically the bone. We are building first the buccal plate, then with the palatal plate, and then we are placing the particulated autogenous bone in between. This is the typical Curie's approach. So this is nothing new, but we are going to this after having collected the right dimension of the bone through a digital work. Now we are working also in this step a little bit different nowadays, because we can work with the digital approach to help us also at this step to decide it in advance how to manage the Curie's block. And this is 4 months after. Also this, nothing new, because the Curie's approach is very predictable in building up the bone vertically. And we have a very nice vascularization, optimal new bone formation inside the anatomical contour. So what we are going to do here is to take out the screws, place the implants. Many cases I work also with a pilot drill guided. So we have once again a digital approach to the surgery. Also is a full thickness flap approach, and also if the implant is going to be placed away freehand. But anyway, the first drill in the static area is useful to be performed with a guide, that be a physical guide, or could be also with a dynamic navigation guide. With not a physical template, but we have now the technology to work with a computer guided approach, but real-time navigation, which is also nice and useful in these clinical situations. So we are placing the implants. Usually I perform also relining. So I cover the bone with a thin layer of bovine bone, particularly in the aesthetic area, because we want to over contour a little bit of the crest. And then this is then the final situation, look into the starting situation where the canine is still the canine of the patient with a new crown, but the result is very nice and is very stable. This is after 4 years, and you see nice and stable where we have a natural dimension of the teeth supported by implants and the teeth supported by the natural root of the patient. So, but going back to the safe cut concept, basically what we are doing in the planning is to decide how to cut the bone three-dimensionally. So we have osteotomy lines. These osteotomy lines are represented by cutting planes, and the external projection of these cutting planes are going to be physically represented by the surgical guide. Then when we are in the operating room, we are going to face the piezoelectric tool against the internal face of the surgical guide, and we are able to replicate the osteotomy lines as planned during the planning. And this is a three-dimensional image of the planning and pre-op and post-op, and you can see clearly that we follow it perfectly, the vertical and apical osteotomy, respecting then the anatomical structure of the alveolar canal. We had a second publication in 2017 in PRD, Periodontic Restorative Dentistry, bringing the feedback of the first 13 patients treated and with many deficiency, where we basically describe how the bone harvesting was anytime related to the dimension of the defect, and where we have described also the approach of harvesting from the chin with the same concept, respecting once again also here the vascular and neurological pedicle of the teeth, so that we had no complication in relation to the teeth vitality or sensitivity. But at the same time, we were able to collect the exact amount of bone needed to perform the bone augmentation. Once and the procedure, when we have the template in place, is really simple, because we need just to follow what has been in advance decided before going to the surgery. So it's obvious that all these potential benefits are related to the thickness, are related to the quantity, are related to the simplified approach compared to the traditional approach. And I want to underline that the starting point is always related to the quantity of bone needed. So if we are looking to this case that we saw also at the beginning, and we have a vertical deficiency with a very poor recipient side, and we decide to work Curie's approach, the first thing we are going to see is that we need to get a certain amount of bone. And it's obvious that if I want to follow this is more than 20, that is around 25 millimeters. And it's obvious that if I'm working freehand, I'm going to take my probe during the surgery and I measure anytime if I'm collecting exactly the right dimension of that bone, of that block. Otherwise, if I'm not collecting that dimension, I cannot work with the Curie's approach. I need to change the technique. But since I can bring this dimension, sternal-oblique ridge, I know since the beginning that I will be able to get that bone. So I'm going to place down my osteotomy lines. I'm going to collect to select the osteotomy lines. I'm going to perform the CAD/CAM process to have my surgical template, and I can, one step more, I can simulate the Curie's approach. So I can divide the block in two pieces. I can decide in advance how to place my surgical template. So my Curie lamina. So I can decide if I'm going to place an occlusal plate and the lateral plate, or I'm going to place one palatal and one buccal. So I can decide all these things in advance. So when I'm going to perform the surgery, I'm going to go straight to the point, because I don't need to decide something during the surgery. I need just to follow what I have decided in advance. So this is the digital plan. And then I'm going to perform the surgery. So I have my surgical template. I place my template in the site. I'm going to perform my osteotomy lines. And then and I can perform, you see, very clear, very clean osteotomy lines. I can save my block. My block has exactly the shape I want to have, exactly the dimension, with no risk to damage the nerve or to damage the root. And obviously I need to perform the Curie's management to increase the bone availability, to increase the biological properties of the bone, because we're going to increase the permeability of the graft to the vascular component. We are thinning the cortical plate, so we have collecting the particulated material, and we have still the cortical plate. Then we are going to have a tunnel approach in this case. We are going to fix occlusal the first block. We have 1 centimeters of vertical augmentation in this case. Completely fill that space with particulated material. And then we are going to place the second lamina. We wait 4 months, and this is the bone. At this stage, we are going to place our implants. 4 months, there was nothing, 10 millimeters for 25 millimeters mesiodistally, and now we have the bone to place our implant. So this is a very great result, and this is before loading the implants. And you see that the implants now are perfectly in a vertically augmented bone. Before there was nothing here, and now we have perfectly osseointegrated implants. But we can do this also in a scenario. Look, for example, this case. We saw also this case at the beginning. Here there was periimplantitis. We have no bone. Look which is the position of the nerve. You see also the external oblique ridge is not so generous. So when we have to collect a lot of bone in this case, we may have also a high risk to be very close to the nerve. But what we are doing, we are simulating the surgery in advance. So we are computer-guided bone harvesting. We can simulate how to manage the Curie augmentation with our harvested block. And when we have done this, we go to the surgical field. And we have no need we are not going to decide something during the surgery, but we are simply perform what we have decided in advance. So we have the computer-guided bone harvesting. We collect the bone perfectly with no risk to damage the nerve, exactly the dimension we want to have. This is more than 3 centimeters block. Then we are augmented vertically following the Curie's approach, and we wait 4 months. And this is the bone after 4 months, and perfectly healed. We are performing dynamic navigation implant placement. So it's also this step, a guided surgery. Then we are placing our implants. We protect this environment with the GBR and a thin layer of bovine bone. And this is after 4 months. And we have built it back everything. Look also where the foramen was, that was on the level of the crest. We have a real anatomical crest completely back in our position. And this is at the time of implant loading. But look also this case in the front maxilla, where we have a not very nice outcome of rehabilitation teeth. We have to work back on these aesthetic and function that was absolutely not nice for this patient. So we perform a mock-up before deciding which type of augmentation, or even if an augmentation was needed, because we can always work with the pink ceramic. We should not forget it. But in this case, the patient asked to use, to augment the bone, to use their gingiva, but look the discrepancy, particularly on the right side between the teeth position and the gingiva, and the bone was even worse because look how is the bone at the edge. So we have vertical deficiency, we have horizontal deficiency, so we are missing a lot of bone. Look into the target we want to reach. But once again, what we are going to do, we are checking on the digital world if it's possible to collect the bone in terms of quantity, how to perform the bone augmentation, horizontal and vertical. And just when we have defined all the parameters, then we are going to the surgical field. But once again, when we are going to the surgical field, everything is already decided. So I'm placing my surgical template inside. We have the all the information needed to perform the surgery. So osteotomy lines following the surgical template. We can collect the bone, and then we go in the upper jaw. We are building here the bone with the cool approach, building up the new dimension, vertical and horizontal. And then we are going to fill this volume with particulated material. But the bone is perfectly, the amount of bone is fitting perfectly to this approach. And we decided to perform an horizontal GBR on the left side. So we have a sausage technique by Urban and a Curie approach very close each other. Okay, so because we need to understand, I like this picture because we need to understand that when we are talking about bone augmentation, we need to use what is good from many techniques and not just one anytime. But we can make a game, or we can decide what is optimal for us in a determined case. And this is the situation after 4 months before implant placement, where the bone is very, very optimal. And look, this is the situation. This is the situation before placing the implant. So we increase a lot of bone before placing the implant. And this is how it heals, which is fantastic. We have very nice bone on the sausage approach on the left side, which was on horizontal GBR, and on the Curie area. So we have very nice vertical augmentation. At this time, we are going to place the implants in the right position. And then we are protecting this environment with a sort of relining with a thin layer of bovine bone to overbuild the area and to protect this volume to the remodeling. So we are fixing stabilizing a collagen membrane and placing some bovine bone to over the crest and protect the crest. Obviously, the membrane need to be fixed because the stability of the environment is one of the most important point from a biological point of view to obtain new bone. So then we are going to place some bovine bone, fix the membrane also on the palatal side. And this is the situation before loading the implant. So we have a very nice bone around the implants in all the area. And when we are comparing these, the start situation to the preloading situation, you see that we increased a lot of volume. Now we are very close to the optimal condition from the heart tissue point of view. And what we are going to do is to increase also the soft tissue, obviously with the free gingival graft and connective tissue graft, to rebuild back the anatomy of the soft tissue. But look at how it looks at the end. We have a nice keratinized gingiva. We are a symmetric arch of the crest. Look at the beginning, look at the end. Now we have a natural anatomy. We have also a natural dimension of the teeth with no pink ceramic. This is the temporary look into the mock-up and the situation from a clinical point of view, the situation in relation to the lip. And we're still working with natural teeth on the left side. So the canine and the two premolar are the patient teeth. And this was the beginning. And now this is the relationship between the lip and the gingiva after the vertical augmentation. And this is then the final situation in the frontal area. So what we obtain is a natural dimension of the crown on the implant compared to the left canine and premolar, where they are the patient teeth, obviously with the new crowns. So this was the starting point, and this is the final restoration. Also, a few years after, 2 years after, this is the situation with a nice shape of the crest of gingiva, and also from a X-ray point of view. So I want to say just as the last case that when we have the chances to perform a digital approach, we could be safe, we could be strongly related to the quantity of bone needed, and we can have a very simplified approach. And going back to the first I show you, Omid, I want to share this case because this is the solution. This was extreme. This was extreme. But it's extreme if we are just starting the surgery with no idea of what doing, or just starting the surgery and think I need to collect a lot of bone because I have 35 millimeters mesiodistal and 15 millimeters vertical. But when I approached this case, I knew since the beginning that I was able to let all the bone needed. So 2 bone harvesting, very safe, maintaining the anatomical structure the right way. We harvest the bone basically from the ramus here, no external ridge, but even from the ramus, and the residual part chin. And this is the situation. And I accelerate a little bit this video, so it's running faster than the normal. But this is the scenario at the beginning. And then we open the flap with the foot thickness approach. We place the surgical guide on the distal area. We harvest the bone from, as I said, mainly from the ramus, which is not allowed freehand because it's very dangerous. But we were able to collect in a safe way a very big block, particularly in the vertical dimension. So in the apical cranial dimension. Look, this is the block from the retromolar area, ramus area, and then we harvest from the chin, from the residual part of the chin, a second block, following the interface of the surgical template. So once again, we respect completely the vitality and the anatomy of the root. Then we build up, you look how was the defect. There was tremendous, mesiodistally and vertically. And then we build the buccal vertical dimension back, the cortical plate on the buccal side, and the vertical dimension on the lingual side. And then in between, we placed all the particulated material. So anything was autogenous bone, 15 millimeters in the vertical dimension. So this was a very big augmentation, but everything was done with the bone that was collected thanks to the digital planning. And this 4 months after, look how is the bone. Obviously, we have a little bit of remodeling, but we can place our implants in the completely generated bone. And here I realized that I can increase the bone a little bit more, 3 millimeters more. And I did it with the sausage approach as described by Istvan Urban. So once again, I combining the two approaches with fixed collagen membrane. And then 4 months. And after 4 months, we perform a free gingival graft. And look here, this was the starting point, and this is the final situation with the completely reestablished in 1 year, 1 year treatment, 3 surgeries, 1 for the bone, 1 for the implant, and 1 for the soft tissue. And this was the beginning after 1 year. This is after 4 years loading, and everything is nice and stable. It is incredible from a biological point of view. This is 5 years. And look how the anatomical structure, the inner structure of the bone has changed from the beginning to 5 years. So we have a completely remodeling of the cortical, internal cortical plate and reinforcement of the external cortical plate. So this is a real integration of the bone augmentation in this extreme 15 millimeters vertical augmentation and 35 millimeters in the mesiodistal dimension. So with this last slide, I want to thank you, Omid, for the invitation. I hope you join this lecture, and I hope to meet you physically in person as soon as this pandemic issue will be ended. So thank you, Omid. I'm ready. And thank you, everybody, for the kindly attention. And I'm ready for all your questions.
Thank you so much, Luca. Well, as I said it at the beginning, that was out of this world. It was a very beautiful presentation, I have to say. It's not a compliment. The way that you described the procedure step by step, the way that you presented, it was just amazing. You are a genius in my eyes, and really thank you for this amazing presentation as always. And it was full of knowledge and really, really interesting, because you mentioned that this is one of the topics and one of the areas in the practice of bone augmentation that most of the practitioners, I think, have a little fear when it comes to harvest the bone, not in fixing the bone, but in harvesting the bone. And that's one of the, I think, the stops and barriers that they don't go for Khoury technique, which is one of the most predictable techniques in ridge augmentation procedures, not only from the horizontal point of view, but specifically the vertical ridge augmentation. And you described the safest way possible. So now I have some questions. The first one, because the guides that you presented, it seems very logical to use. And first thing I want to know, is it possible for all the lab technicians to make this guide, or there is a specific protocol? And for those practitioners interested, should they order the guide with their CBCT sent to a specific center, or it's possible to do it everywhere in the world with the practitioner knows what is doing?
Oh, thank you first for the appreciation of the lecture. And I think you get the right point. I want to focus back on your first words, that sometimes the biggest, or I think because I was back from my Khoury's training in 2008 back in Italy. Mm-hmm. And from 2008 and 2012, I taught the typical Khoury's approach with the freehand bone harvesting and the micro-saw approach, which is a fantastic approach, there's no doubt. But there was any time a big barrier between the Khoury technique and the bone harvesting. Because the people was really afraid by doing that. And also by teaching all the tip and tricks on diagnosis, on surgical. We have always to keep in mind that we are alone in the surgical room.
Yeah.
And I think that the dentist, when has learned everything, then he start doing it the first time, and he's selecting a small case, it will be for sure, I would say, safe on performing the bone harvesting. But when he start to grow and wants to treat bigger deficiency, and then you have to increase the dimension of your block, it means that you have to go close to the anatomical limit, then the stress of doing something wrong is going to grow a lot. And remember that the stress is in the base of surgical mistakes. And so when we are working with stress, we are not working good. We're not happy on performing surgery. And we want to finish the surgery as soon as possible. Yeah. And then the temptation to open the bone from a box is very, very high. And what at the end, you stop working with the Curis approach and you decided to work with the GBR and just scrape a little bit of bone. But as you said, the predictability of the Curis approach is incredible, yeah, particularly in the vertical augmentation. And when in 2012 we changed this protocol, I feel happy myself because I reduce also my stress, surgical stress during the surgery. But I felt immediately the other dentists were approaching the Curis approach in a completely different way, because there was a solution for the critical. As you said, nobody is worried to screw the block. Yeah. The problem is to get the block. Yeah. And this approach really bring down the learning curve and say and a lot of self-confidence for the surgeon. And this helps the surgeon to perform the surgery even better, because they have the feeling to have control, which is true. They have control of what they are doing. So, going to the second point, so I completely agree with you that the crucial point when someone is starting working with a Curis approach is not screwing the bone, is to get the bone. And this is a way how we can avoid the problem related to the bone harvest and to bring this step very simple. Yeah. Now, how we can develop this, or how we can perform the surgical guide. Now, the process, I'm going to be crystal clear with you all. Process has been patented. So actually the technology is a Nobel Biocare hands. So they have the patent, but we as inventor have the chances to support clinician or lab, if they want to have the technology, till Nobel Biocare will come on the market. Yeah. So if there's someone as want to have a surgical template, can I will send you, Omid, the reference email, which is anyway service@guidedsurgery.it, to have all the support, technical support and clinical support to perform it. Because we can, the technology is so simple, because we can manage also sending STL file. Yeah. And then if you have a 3D printing, you can print yourself. Yeah. Or can the lab print for you. So is very, I mean, digital is working, simplified everything. Yeah. From this point of view. So we can manage worldwide in a very easy way. So I think is going to change at least for the clinician that start working with this, change completely also their surgical limits, because now they are treating bigger cases that before they were worried. So this is useful not for just for the beginning, I would say. I mean, is useful also for the advanced surgeon, because they can do things with less stress and also bigger things, as last case I show you. If without the digital approach, I was never able to think to do like something like that.
Exactly, Luca. I'm totally agree with you, because in so many cases that we are doing it freehand and with no guides. For example, we are going to harvest a 3 millimeter thick plate or block, but at the end, we ended up with 1.5 millimeter thickness, because sometimes, because of that fear, because we are not exactly sure how far we go deep or how far we go horizontally, because of fear, we harvest the amount less than the one that we need. And usually, again, because of that fear and because of not having that accuracy without the guide, usually practitioners really don't tend to go harvest bone from many areas, because they're not sure what will happen. But the way that you described it, and the confidence that is given to the practitioner with that guide and with that precision, then it makes the day, and we can do the surgery the best way possible. Now, my second question is this: regarding because you showed it in the animation also, that, for example, we want to go 7 millimeter deep. When we place that guide, how we should measure the depth of going inside the bone? Should we put, for example, a periodontal probe on the tip of the piezo surgery a head unit to measure the depth of insertion, or it's also already measured on the guide? Because I couldn't find out how we control the depth of insertion.
Yeah, that's a good point. Thank you for asking. I use a piezo tool that has dots on 7 millimeters, 9 millimeters, and 11 millimeters.
Yeah.
And we measure any time from the bone, because we can decide to have the thickness of the surgical template can be changed based on needs, on the surgical needs. So any measurement are given from, or are considered from, the bone level. So usually we look on the piezoelectric tool, and we bring down till the first dot, for example, the 7 millimeters dot is reaching the bone level. But I think the other point which helped the overall approach is that the piezo tool is going to be brought inside the bone with a lot of control in terms of vertical. It's not like boring a bone that you fell down in the soft bone. So you advance very slowly with a very controlled. So you can really check each millimeters of advancement. And because the point here, as you said, the real point is the three-dimensional direction.
Yeah.
Because if I know that I'm moving in that direction, I know exactly how safe I'm going to be. Mm-hmm. And I didn't show you it during the lecture because I was thinking that I want to start with more typical approaches. But we had some cases where the nerve was very cranial, and we ran with the vertical osteotomy between the cortical plate and the nerve. Yeah. So in between. And we have the post-op CBCT data showing us that we were perfectly between the two anatomical structure thanks to the surgical guide. So we overcome a cranial position of the nerve, maintain anyway the safeness of the process. So once you are starting using and you see how accurate is the system, then you can really bring your limit very close to the anatomical structure. Usually we plan to be not closer than 1 millimeter, but this means that we can collect a lot of bone.
Yeah. Yeah.
And we can go also into the ramos.
Yeah.
We can go more distal because we are always anytime cranial to the nerve. So we can go more distal and more mesial with no risks.
That was also a great point that you mentioned. And you know, I'm still thinking about the cases that you presented because there were massive defects. And you know, the way that reconstruction happens, as you said, in one surgery for the bone, one surgery for the tissue. So it's just I think it's logical to think about this technique twice because so many people still don't do this technique because of those fears maybe, but we should be always predictable in our treatments. And how can be more predictable than that? Because we've seen so many sausage techniques, we've seen so many workings with the non-resolvable membranes, Huri plates. But speaking of complications, possible complications that may happen, I can safely say that in this technique, if we do it properly, I think the risk is going to be lower compared to non-resolvable membranes or titanium meshes. Luca, your cases was beautiful, and I know that I can talk about it like hours and hours, and I don't want to really take your time more than that. But just one more thing that I want to ask you, because it's one of my personal concerns sometimes in my cases. When we take CBCT of the patients, as you presented in some of your cases, they have a very good buccal shelves, and we know that we can harvest something there. But in some cases, we really don't have that shelf and that thickness. So maybe we are very lucky to go and harvest only a plate. In those cases, I think with seeing your presentation, in those cases, I think the best option going to be guided. But I want to know your experience. If you don't have enough thickness in the buccal shelf, is it affecting your decision in choosing this technique comparing to other techniques? Or even in those cases, your is going to be Khoury technique?
Oh yeah, this is a good point. I mean, the possibility to harvest the bone, it's for sure a cross point. Mm-hmm. I mean, if I have the chances, what I'm doing, I collect the CBCT data, I try to get a virtual walks-up of the future tooth position, so to define where I can place the implant or where the implant should be placed. Then we know exactly how much bone should be collected. Then I check if I'm able to collect that bone. And I would say that till now, we had always the chances to get that bone. Mm-hmm. We look on the chin area, we look on the other side, we can plan eventually a double bone harvesting, but sometimes we have maybe different defects in the same mouth, so we have to have a lot of bone. Then I use also non-resolvable membrane in some cases. I mix the autogenous bone with some bone substitutes. I use also autologous plates. So there are other chances and other approaches, obviously. My first choice is always Khoury. If I cannot follow that protocol, I will change to other protocol, using also some bone substitute. I mean, we need to adapt the approach to each case. But my first choice is Khoury when it's vertical, more than 4 millimeters. When I'm not going to place the implant simultaneously, then is Khoury my approach. But for example, if I have limited vertical deficiency, for example, 3 millimeters, and I can place the implants simultaneously, then I use also non-resorbable membrane. So I would say, Omid, I'm not married with a surgical approach. I prefer to have the chances to change any time.
Yeah, I got the point. I got the point because I really wanted to hear that from you, because we should know different techniques, but definitely the priority in our choice will be affected by the predictability of the technique, as you mentioned. Luca, I have to say
Absolutely.
again, yeah.
Absolutely.
I have to say again and again, I'm so thankful that you accepted the invitation. It was my pleasure to have you on Hot Seat with your amazing topic. I'm pretty sure so many people will enjoy and continue to enjoy your beautiful work. And I'm very gonna be interested to have you soon in my country at the Symposium of Complications in Implant Dentistry, which I run every year. And hopefully after this COVID situation, it will be my honor to be your host in my country. And hope to see you very soon, my friend. And
Thank you very much.
Thank you so much again. Stay
Thank you.
safe and hope to see you very
Thank you. Thank you.
Thumbs up.
Thank you very much. Thank you. Thank you very much. Hey, ciao.
Ciao. Thank you.
Ciao.